Okay, guys, I know that there are still some people who will be hopping on in a few. Hi, Janie. But could I have Mark Baumgartner open us up in prayer, please?
Sure, I would be happy to. Let's pray. Gracious Father, we do thank you that we can come to you and ask for your help and ask for your blessing now on this meeting. And I do ask that you would use the participants on this call to instruct us and to help us in the cause for life. Lord, I thank you for Rachel and her mother Suzanne and all the good work they're doing to educate us and others about these issues. We ask your blessing on the technology, Lord, that it would not be a problem, and Lord, that we would be able to hear clearly, and Lord, that you would use this time to instruct us and bless us. In Jesus' name, amen.
Thank you so much, Mark. Well, I am really excited to have everyone on this call. I'm so excited to have the three speakers, Dr. Anthony Caruso, who's on, and then Dr. Will Lyle and Dr. Monique Ruberu. So thank you all. As we are waiting for Dr. Lyle, would anybody be interested in kind of sharing where they're from so that we can see just kind of the wide span of how many states are represented on this call? I'll start. I'm from Georgia.
I'm Mark Baumgartner from Columbia, South Carolina.
Rachel, I'm down the street from you. Lisa Regan from Pregnancy Aid Clinic in Metro Atlanta.
Yes, you are.
I'm Jill Stanek from Chicago.
Hey, we're the Washingtons. We're in Canton, Georgia, and Rachel's story was really major for us. We have a 15-month-old little girl that was 7 weeks premature, and my water broke at 19 weeks. And so Rachel was praying for us and in touch with us the whole time as we went from 19 weeks to 22, 23 weeks when the doctors said before that they wouldn't try to save her life. So we're really interested in this and just so grateful for the work she and Suzanne are doing.
We love our Washington family. Well, I know Janie, she just recently moved down here from Georgia, and she's doing a lot of pro-life work with Jill. So that's super exciting. She's been trying to get connected with all the different crisis centers and ministries down here. So it's really awesome.
Hey, Rachel, I'm happy to be here.
Oh, well, thank you for being on.
Hey, Rachel.
Hi, how are you?
I am doing really well.
Thank you so much for being on tonight.
Oh, absolutely. Is my video coming through?
It is not yet.
How about there?
Perfect.
All right, good deal.
Thank you so much for being on. Well, everybody, okay, we have two of our three speakers for tonight. We will get started. Mark Baumgartner opened us up in prayer. So I'm just going to give a little bit of introduction about each speaker, and then I'll have them share a bit more about themselves. But Dr. Lyle, he is a practicing OBGYN in Florida. He has a strong passion for the preborn, and he has a specific heart for the babies who have health conditions in the womb. And so to be able to really fight for them and to show their value and to recognize, oh, no matter how long they live inside the womb or outside the womb, that they're worth fighting for. And that just really is like his specific expertise and passion and what he shares about across the nation. So thank you so much, Dr. Lyle, for being on. And if you'd share a bit more about yourself, that'd be wonderful.
Sure. I'm board certified in obstetrics and gynecology. I'm licensed to practice medicine in both Florida and Alabama. I've been an instructor with the University of Florida OB residency and with the Florida State OB residency. The practice that I took over in 1999 actually was the largest provider of abortions in our Pensacola Tri-County area. We stopped all abortions on day one, stopped all referrals, and we had the physician sign a restrictive covenant when we took over the practice where he couldn't practice any more medicine at all for the next 2 years in our geographic area. And short story, he retired, he moved back to Sweden, but that was in 1999, and was when I actually, on a Sunday after church, I went up to the surgical suite, and we'd never toured the upstairs, and I saw the abortion machine and all the equipment, and I couldn't help but think how many thousands of women over the previous 30 years had gone up one set of stairs with a baby on the inside, spent a half hour up there, and then went down the other set of stairs without that baby on the inside. And I mean, this is just a mile down the street from Pensacola Christian College, from our Catholic hospital, Sacred Heart Hospital. So we made a commitment to teach our general close area about what was going on, to teach how we treat the preborn as patients. We just spent $70 million on our new women's and children's hospital to treat the preborn as patients. And we can go over that in a little bit more detail. So my profession is delivering and obstetrics and gynecology. My passion is serving the needs of the preborn and defending them. Delivered about 4,000 babies and have been in practice since 1999.
God bless you. Thank you so much for giving more of an introduction of your heart for these babies and for all that you do for them. Thank you so much. Well, if you would get us started on your presentation, that would be incredible.
Okay, well, bottom line is we treat the preborn as patients. And, you know, that's what every obstetrician does, is we treat the preborn as patients, from the first ultrasound, from the first lab work to the delivery. We're always communicating. We're listening to see how the baby communicates with us. We listen for the heartbeat on every obstetrical visit. We listen to the heartbeat during labor to make sure the baby is communicating that I'm doing okay, I'm tolerating labor. Even from the very first visit, we get a set of blood work, and we want to see what the mom's blood type is. We want to see if she has any infections or if there are any concerns that we need to have for the baby, because when we practice obstetrics, we always have two patients. We have the mom and we have the baby. They are very different patients. They have a different blood type often. They have different needs. In fact, one of the first blood tests that we do is looking for an antibody screen, where we look in the mom's blood to see if she has antibodies in her blood, which can attack the new pregnancy. And there's lots of different potential antibodies, but the reason we look for these, because we know that there are several, KID, KEL, Duffy, which can actually cross from the mom's bloodstream, go across the placenta, and actually start to attack the baby's blood, because the mom sees the baby as not part of her, but as a totally different person. And sometimes it can almost be as if somebody got a kidney transplant. That kidney might be a close match, but it's not their kidney. So the mom's body sometimes will see this new person from the very beginning parts of the pregnancy as foreign. And these antibodies go across the placenta, and they can start to attack the baby's blood and lower that blood count so much that if we don't do something, those babies can die on the inside. And what do we do when an adult's blood count is really low? Well, we give adults a blood transfusion. Say you got a bad cut or a bad accident, we give you a blood transfusion. Well, we can do that for the babies as well. And even at our hospital, we've given babies blood transfusion through a procedure called a PUBS, which is a periumbilical blood sampling. We take blood and we take a long, thin needle with guiding from an ultrasound. We guide it through the skin of the mom, through the wall of the uterus, right up to the umbilical cord, and we give that baby a blood transfusion. Just as if you got a real bad accident or a cut, we give that baby a blood transfusion. There's a field of medicine called maternal fetal medicine, high risk obstetrics. And we don't have time to go into all the details, but it's amazing. Not only do we give babies blood transfusions on the inside, but we can actually do surgery on babies on the inside. One of the surgeries that's commonly done is when you have twins that are sharing one placenta. And I had a patient who had twins. They were identical twins, and they were sharing one placenta. Well, if sometimes kids don't share nicely, and these twins were not. One was growing at the 90th percentile, one was growing at the 10th percentile. And we actually needed to teach these two babies how to share nicely. So we sent her down to Texas Children's Hospital in Houston, and we did that. They actually went in with a laser, and they can use a laser under a procedure called fetoscopy, where they actually can divide the placenta in two. Essentially, you share that half of the placenta, you share that half of the placenta. So we can teach them how to share on the inside. We can actually remove tumors. We can treat spina bifida. We can actually do heart surgery as early as 22 weeks gestation. One of ACOG's big statements is that a patient is a person and is deserving of respect and bodily integrity. If we're doing heart surgery on these patients, if we're doing spina bifida surgery on these patients, if we're doing blood transfusions on these patients, then they are persons. And if a patient is a person, regardless of how small, we need to defend them and protect them. But that's just some of the ways that we treat the preborn as patients. But, where else would you like to go, Rachel? We can talk about that. We can talk about abortion pill reversal. Where would you like any particular area? Because I can talk for 2 hours.
Well, I love that. Thank you so much. Thank you so much for sharing about all that can be done for these preborn babies in the womb. If you could share also about abortion pill reversal and the importance of, and I know this isn't new necessarily to those on the call, but just the importance of physicians doing abortion pill reversal would be phenomenal too.
Sure.
Thank you.
Well, a lot of times we need to start with definitions. Yes, we treat the preborn as patients with all the different ways. We have nurseries now which are saving the lives of babies at 23 weeks gestation. We can do DNA testing. There's a test called a panorama, which is something called cell-free DNA, where 7 weeks after conception, we can get a blood test on the mom. It's like mom comes in and congratulations, we do an ultrasound, and it's been 7 weeks since conception. DNA is the story of who we are. That is our blueprint. And of the 7 billion people on the planet, all 7 billion have a different blueprint. We all have different, unique DNA. Just how you can have somebody who is trying to solve a crime. They can have one cell with the DNA from one cell, and they can match that to somebody who had committed a crime, and with excellent assurance that this one cell came from that one person. Well, a baby is a perfect combination of the mom's DNA and the baby's DNA. And it's unique from the mom and it's unique from the dad. And we've always known that there were little fragments of this DNA that crossed from the baby to the placenta and then circulated in the mom's bloodstream. But we also know there's a lot of fragments of the mom's blood and DNA that are in that bloodstream. Well, how do you separate out what's baby's DNA and what's mom's DNA? Because 95% of these fragments belong to the mom and 5% belong to the baby. It would be like if you had a bowl of sugar and I just put a pinch of salt in there. And Rachel, I asked you, can you do me a favor and take out all the salt that I put into that sugar bowl? You're like, I can't do that. Well, the same is true with DNA for the baby. But now we can actually remove that salt. We can remove that baby's DNA. We can take mom's DNA and put it over here, baby's DNA and put it over here, and we can actually analyze that baby's DNA. Just like if you've ever done Ancestry.com or 23andMe, you get a coupon, it's $50, and they send you a little vial. You put some of your saliva in that vial and you send it off, and a couple weeks later you get a report. And they have just told you about your great, 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 great grandparents. They have gone back on your mom's family tree and your dad's family tree. You're 12% Irish, 19% French, 10% English. And they tell you your family tree. They tell you the story of who you are and who your ancestors were. Well, we can do that with the baby's DNA. And we can do that again 7 weeks after conception. We can even tell you the gender of the baby with a blood test on the mom 7 weeks after conception. So we know that we are unique, but when are we unique? We're unique when we're born. We're unique when we get our ultrasound done. But what's really important is that even at that moment of conception, when it's one cell from your mom and one cell from your dad came together and an exact copy is made, if you could just take the DNA from that one cell and send it off to ancestry.com, it would be the same as if I did that.
When I walked by
Yeah.
like 5 seconds ago, I was leaving in 5 minutes, and now I am not.
Can everyone make sure that they are on mute?
No worries.
No, you all are fine.
So like I did my ancestry.com, sent it off, and it gave me my report. But that report doesn't tell me the story of my family tree on the day that I was born. It's not like I was nobody and then all of a sudden I get welcomed into the family on my birthday on June 20th, 1965. No, I was part of that family tree, not just on my birthday, not just, when I had a heartbeat out. My DNA was the exact same at that moment of conception. When one cell from my mom and one cell from my dad came together, that made me unique at that time. And it never changes. And we look at anatomy and we think as like we do robotic surgery and somebody goes home same day. It's like, wow, we're really special. Now, what's really amazing is we were all one cell, and then we've got to get bigger, but we don't just want to be one big, huge cell. So we divide into 2 cells, and then 4, 8, 16, 32, 64. We're all sitting here at like 50, 60 trillion cells is what we end up at being as adults. But when did we start changing? As fetal development happens, we don't just want to have exact copies. We have lots of different cells in our body. So early on in development, you have a couple of cells that divide. And then one cell, you know what? I don't want to be just like you. I don't want to be an exact copy. I don't want to be an exact like the person next door. We're all unique. We're all different. So one cell will say, you know what? I'm tired of being an exact copy. From now on, I'm going to start the entire circulatory system. Another cell looks and says, that's pretty cool. You do the whole circulatory system. I'm going to start the entire digestive system. And another one says, well, that's all right. You guys do that. I'm going to start the whole neurologic system. It's like they all had the exact same blueprints. They had the exact same plans. And then one decided, I'm going to be the plumber. Another one says, I'm going to be the electrician. The other one says, I'm going to frame out this house. Another one says, well, I'm going to make all the skin. I'm going to be the roofer, and I'm going to put up all the siding. It's called cell differentiation. We have guesses on how it happens, but to be honest, we really don't know. But it does prove one thing: with a design like that, there had to be a designer, where when we're just a little blob of cells and they decide this is the part of the DNA that I'm going to read. And it's like, you know what? I'm just going to develop all the arteries and the veins and the heart. That's going to be my job and my contribution. So it's amazing how much happens just during the first month of a pregnancy. But we treat the preborn as patients. And there's a big threat. We know that there have been 62 million babies that have lost their lives in the womb since Roe versus Wade was passed in 1973. The fastest growing form of abortion here in the United States and worldwide is with the abortion pill. This is where we have to define things. I do a lot of radio, and I recently did a radio show with a conservative radio host that's been doing conservative news for 30 years. And I said, well, we need to talk about the abortion pill. Because I know all about that. He says, that's, they can take that in the first 3 days. I'm like, no. That's the morning after pill. And the morning after pill is taken 3 days after a woman has had sex. The abortion pill is indicated for up to 70 days after the first day of the last menstrual period. 10 weeks. Is it effective? Yeah, it's about 96 to 98% effective in taking the life of a baby up to 10 weeks gestation. We've all seen videos and pictures of early ultrasound, and it's like, oh, my baby's 8 weeks, it's 9 weeks. I've got a picture of my daughter at 12 weeks who's jumping and sliding inside the womb. At 9, 10 weeks, you see babies moving around. That's the gestational age that we're talking about. Well, how does it work? Well, it's really two different pills. The first, what's known as the abortion pill, which is also called mifepristone, blocks a very important hormone. When a woman gets pregnant, lots of changes are happening because the body's new job is to support the pregnancy, you know, and if it's never done that before, there's a lot of changes that have to take place. The body is saying, we need to send out a signal to the body that we've got a new full-time job, and our full-time job is supporting the pregnancy. Well, who sends out that signal? You know, it's almost, my oldest daughter was a music major at the University of Florida, and she played violin. And like before they play an orchestra, when they're all tuning up, it doesn't sound good until the maestro, the conductor, comes out, and the conductor kind of taps his little stick on the podium, and then he conducts. He organizes. He says, you need to do this now. You need to do this now. We're going to do it at this speed. There's a hormone that really acts like the conductor of pregnancy, and that hormone is called progesterone. Progestation. This is the hormone that tells the body, we're going to support the pregnancy. We're not going to have a menstrual cycle. We're going to have the uterus get bigger, because the uterus starts off about the size of a lemon, and it's got to grow to about the size of a watermelon. Lots of different changes need to take place. And it's this hormone that sends signals to the body that says, we're going to support this pregnancy. Well, how does the abortion pill work? Mifepristone is very effective in blocking the signal from this hormone. Progestation. It's almost like that is the song that is playing, is progestation. And mifepristone essentially puts earmuffs. The abortion pill puts earmuffs on the body, and the body's like, you know what? I was hearing this song about, hey, we're pregnant, and I don't hear that song anymore. So if we're not pregnant, then I guess we've got to have a menstrual cycle. We have to withdraw all the support for the pregnancy that I thought was there. So how effective is it? It's 96 to 98% effective up to 10 weeks in taking the life of the baby. But then the next day, there's another pill that's taken, and that is called misoprostol or Cytotec. Cytotec is a prostaglandin. Now, we use Cytotec in pregnancy. We use it because one of the properties of Cytotec is it causes the uterus to contract. Well, if you're 40 weeks pregnant and it's your due date and you're not going into labor on your own, we can use that pill Cytotec to actually start to have contractions. In fact, by the FDA, it's labeled as category X, which means don't ever give this to somebody who's pregnant, because it'll put her into labor and she'll lose the baby. Well, in very low doses, we can use it to induce labor very safely. And what are those doses? About 25 micrograms of this medication. Now, when somebody is having an abortion, they've already taken the first pill, the mifepristone, the RU46, the abortion pill. The next day, it's killed the baby, but now we've still got the baby on the inside. Well, what do? Well, you have to have something that's going to squeeze the uterus, which is going to squeeze the placenta, the fluid, and the baby out. And that's done with this pill Cytotec. Now, if I have a patient who's 41 weeks pregnant, she has a 9-pound baby in there, I'll use 25 micrograms, which will get that uterus to contract. When you're having an abortion, they use 200, sometimes 400 micrograms. So 25 to deliver a term baby, 200 to 400 to squeeze out an abortion. Can it be reversed? You might have heard that. Yes, absolutely. In fact, to date, we use progesterone in normal pregnancies all the time. We use it for women who've had recurrent miscarriages. We use the hormone progesterone to keep the pregnancy going. We use it to prevent preterm labor. I delivered a set of triplets a few months ago. She never spent a night in the hospital. She got to almost 33 weeks gestation with her triplets. And the only thing we gave her was progesterone, because we use progesterone to prevent preterm labor. Remember, progestation, keep the gestation going. But even people who get referred to us after they've had in vitro fertilization, their body kind of got a surprise. I mean, all of a sudden, baby was transferred to the uterus and it wasn't expecting it. So every baby who is transferred with in vitro fertilization is given a hormone, progesterone, the exact same medicine that we use to reverse the abortion pill. Everybody comes into our office and they're already on progesterone. So we use it to prevent preterm labor. We use it to prevent miscarriage. We use it with higher multiples and even with in vitro fertilization. So it's not like this medication that is dusty and sitting on the shelf somewhere. It's like, should we use it? No, we use it all the time. I mean, every obstetrician uses it. So when somebody is in a position where they think the right answer is to take the abortion pill, and they go to the clinic, they get told about the abortion pill, they get explained the protocol, they sign the consent, they swipe their credit card, and then they're given the abortion pill. We have lots of patients have regrets. If we give them progesterone, so they had their own progesterone, then they have a progesterone blocker, well, then we're just turning up the volume on this radio. We turn up the volume on the progesterone. So the body's going, yay, we're pregnant. Ooh, we're not pregnant. Oh, that's okay. Yes, we are pregnant. And that's how we can be successful. We have healthy moms and healthy babies. And as of December 2019, we have documented over 1,000 pregnancies, which we have successfully reversed. I'm now 7 for 8 in our area, where I've tried it 8 times and I've been successful 7 out of 8 times. And since we use this in obstetrics all the time anyway, it's not like, well, you reverse the abortion pill, but what kind of problems is the baby going to have? Is it going to be missing arms or legs? No. This is all or none. This is either going to be a red light or a green light. We're either going to be successful and you go, yay, or we're not going to be successful. It's not that you're going to be successful and there's a baby that has lots of problems and issues. So we have a organization called abortionpillreversal.com, and there's another name called abortionpillrescue.com. We've trained over 500 doctors, nurse practitioners, physician's assistants nationwide. I was in Ireland and we did a bunch of training of doctors and pharmacists in Ireland on how to reverse the abortion pill. And they've already had 2 successful reversals since we were there in Ireland doing the training. But we have a network of nurses that man our 800 number. And to give you an idea, here's one of my patients. This is how it works. The patient was about 9 weeks pregnant and she'd had an ultrasound. She was 9 weeks pregnant. She was getting lots of pressure from her boyfriend saying, you do something about this or I'm going to leave you. Well, she should have left him anyway. So she calls up to Tallahassee because they had an abortion clinic up in Tallahassee. She says how far along she is and she tells him she wants to get the abortion pill. Well, they say, we're booked up. We can't fit you in for at least 2 weeks. You needed to call another clinic. And she's like, but in 2 weeks, I'll be past that 10-week point and I can't do the pill. So she calls all the way and she finds a clinic over in Jacksonville, Florida. She calls Jacksonville, says, I'm 9 weeks pregnant. I want to take the abortion pill. And they said, well, it's a long drive, but we can see it's about 5 hours to Jacksonville in the Atlantic Ocean. This lady lives here on the Gulf Coast. She drove 5 hours to Jacksonville, Florida. She drove 5 hours. She took the pill, she signed the consent, she paid for it, and then within, 15 minutes, she's back on the road. She's on Interstate 10. She's on Interstate 10 and she sees one of those signs on the side of the road that says, heartbeat at 18 days, and it shows a picture of a little baby. Then she's driving a little further along and she sees another billboard and it says, your mom chose life, shouldn't you? And she starts to feel really guilty. And she's like, what did I just do? I mean, I know I'm 9 weeks pregnant. I saw the baby's heartbeat. I saw the baby on the inside. So she didn't know what to do. So she pulls off at a rest area on Interstate 10 and she gets out her smartphone and she Googles abortion pill antidote is what she Googled. Well, that took her to our website. And then she called the toll-free number. She spoke with one of the nurses. And the nurse got all of her information. How far along are you? What medication did you take? Do you have any allergies to any foods or medications? What's your pharmacy number? And they get all that information. They said, is it okay if we have one of our physicians call you? She goes, absolutely. So I called her and they gave me all the information. I spoke with her, told her what to expect, how this isn't perfect. We're about 70% successful if we can start the reversal medication within the first 72 hours. Well, this has only been a couple of hours now since she took the medication. So I spoke with her and she goes, absolutely, I want to take this. I said, well, I'm going to call this in to your pharmacy by your house. So you can just go straight to that pharmacy when you're getting close to home. So she did that. So I called the pharmacy and I spoke with the pharmacist and I said, hey, it's Dr. Lyle, just need to call in a prescription for Prometrium. And I gave her how many pills and how to take them. And then she paused and she said, Dr. Lyle, are you trying to reverse an abortion? And I said, yes, ma'am, I am. And I said, I want to give you my credit card because she's just spent all of her money on the abortion pill. And I don't want there to be, have cost be a problem with her getting started on the medicine tonight. And I said, I want to give you my credit card. And she goes, no, I'm not taking your credit card. I said, I really want to pay for this. And she goes, nope, I'm going to pay for this out of my own pocket. And so the patient got to the pharmacy about, 3-4 hours later. And I called her later that night to make sure she got the medication, got started on it. And I said, hey, it's Dr. Lyle. I said, were you able to get to the pharmacy? And she said, Dr. Lyle, that is a strange pharmacy. I said, what are you talking about? And she said, I went in there, I gave the lady my name in that little private area over on the side. And she said that she came from around the corner. She gave me a big hug. She told me she'd be praying for me. And then she said that she had already paid for my medication. I said, well, did you get started? She goes, I already started the medication. I said, that's great. I want to see you in my office this week. So I saw her in the office on Monday and we had a heartbeat, but it's only been a couple of days. We saw her in the office the following week. We still had a heartbeat. And then we saw her the third week and we still had a heartbeat. And I guess it was in April, I actually delivered that baby. So that baby had a 96, 98% chance of dying. But because somebody felt the need to put up a billboard, somebody felt the need to be working at a hotline, a pharmacist was very compassionate and understanding. I made myself available. If any one of those people hadn't been involved, then that baby probably wouldn't have survived. So after, 6 weeks afterwards, she came in for her postpartum visit. And I said, boy, and baby's beautiful, absolutely gorgeous baby. Mom's happy, baby's all dressed up. And we had to stop and pause and said, boy, do you remember where we were 7 months ago? I mean, it's just amazing, how a lot of people get involved and a life is saved and a life is changed. So, there's lots of people that are involved in the abortion pill reversal, abortion pill rescue. There's doctors, there's nurses, there's nurse practitioners, there's physicians assistants. And do I remember all of the babies that I've delivered? No. I mean, I've delivered 4,000 babies. I remember my triplets, I remember my quadruplets, and I remember every one of my abortion reversal babies because, they're special. They're unique. This is a baby that was going to die at 7 or 8 weeks gestation. And then you assist them and you're able to save the life of that baby. It's kind of like, I was a lifeguard when I was a kid. Did nothing but sit on the side of the beach, twirling my whistle for 4 years until one day I actually had to go in. There was a kid that was drowning. I don't remember anything about 4 years working as a lifeguard, but I remember so many details of the one time where actually, oh my gosh, there's somebody drowning, and went in and saved that kid. It's kind of the same thing when it comes to the abortion pill rescue. And you'll hear Planned Parenthood say that nobody regrets their decision to, have an abortion. They take the pill and everybody's happy. Well, that's not true. Most of the reversals, when people will call our hotline, happen within the first day or two. A lot of times they happen in the parking lot of the abortion clinic. And I was reading a story about suicide. And the Golden Gate Bridge in San Francisco is one of the most common places that people will take their lives. And there was a psychologist who knew that since the Golden Gate Bridge was built, about 1,800 people have jumped off the Golden Gate Bridge to take their lives. But she also heard that a lot of people survive when they jump off the Golden Gate Bridge. So she actually sought them out. She was able to find 29 people that survived jumping off the Golden Gate Bridge. I mean, they had 1,800 people that had jumped and had died, but she found 29 that survived. And she set out to interview all of them. And what she came to a conclusion was, consistently, every one of them walked out onto the Golden Gate Bridge thinking, nobody loves me, nobody cares for me, the world would be better without me in it, I have nobody to turn to. So they walked out onto the bridge and they jumped off. But she also asked them, what were you thinking after you jumped off? 29 of 29, all of them said as soon as they jumped off that bridge, had immediate regrets. They saw the bridge up above them and they just cried out, they said, I don't want to die. And all of a sudden they had a huge desire to live again. And by some miracle, their lives were spared and they survived. Same thing happens at an abortion clinic where somebody will walk into the abortion clinic. They'll say, nobody loves me. Nobody loves this baby. The world would be better without this baby in this world. I don't have anybody I can turn to. I have no help, no support. And then they walk in and they think that they are doing a good thing. And then as soon as they take that pill, they have immediate regrets. Just like somebody who jumps off the Golden Gate Bridge had immediate regrets. Somebody who takes that abortion pill has immediate regrets. The biggest challenge is educating people that a reversal is possible. I mean, we reverse medications at our hospital all the time. Narcotics are a huge issue here in the United States. I mean, we have, 50,000 people that die each year from a narcotic overdose. So if somebody comes into our emergency room and they've overdosed on a narcotic, the medication that we give them all is Narcan. Narcan is amazing. It's like Sleeping Beauty. Sleeping Beauty's asleep, Sleeping Beauty's awake. I mean, and we give them, and Narcan saves lots of lives because the narcotic has given them too much narcotic. They now aren't breathing. You can't yell at them. You can't rub their sternum. You can't wake them up. You give them Narcan and it's just like turning on the switch. Somebody who isn't breathing, doesn't seem to be alive except for a pulse, all of a sudden within 30 seconds will sit up, they'll start talking, they'll start breathing on their own. So Narcan is the antidote for a narcotic overdose, just like progesterone is the antidote for somebody who's taking the abortion pill. Is it perfect? No. I mean, our records show that we are about 70% effective. But when we are successful, it's a healthy mom, healthy baby. And everybody got into obstetrics because they wanted to have healthy moms and they wanted to have healthy babies. And this is one of the most unique ways that a physician or a nurse practitioner or a PA can get involved and use the knowledge and skills that they have. It's, California just spent $205 million to put a netting system underneath the Golden Gate Bridge because there were so many people wanting to commit suicide that they said, we're going to try to save some of them. Well, that's what we're trying to do with the Abortion Pill Rescue Network, is we realize there are a lot of people who make the wrong decision. For whatever reason, they don't recognize this life and this new person and this gift of life that's there on the inside, and they make a wrong decision. So somebody who takes too much narcotic, is that the wrong decision? Yeah. Do we have a duty and an obligation as physicians to reverse the effect of that narcotic? Yeah. When somebody takes the abortion pill and then they recognize that was the wrong decision and they come to the emergency room and they call our hotline, they go, I did something really bad. I did something really wrong. Is there anything I can do to reverse this? Do we have a duty and a responsibility to help them through that? Yeah, we sure do.
Okay, good. Thank you so much, Dr. Lyle, for sharing. I just cannot put words to it. Thank you so much. Thank you so much for your passion and for all of these precious little ones and fighting for them and for explaining about the importance of the abortion pill reversal. I mean, that is so huge and such a such a gift to be able to hear about those beautiful stories that you shared about with patients of yours, of the beauty that no one regrets choosing life, but yet people do regret aborting. And thank you so much. And thank you for sharing also about those babies with the health conditions, because yeah, I
Well,
mean, the little ones, they need to
but
be.
you know, we can't save all their lives. I mean, there are times, just like we have a patient that comes in and we diagnose them as an adult with, say, a grade 4 astrocytoma. They have a tumor in their brain, and unfortunately, they are going to die. We just don't have the the technology and the therapies which can cure a grade 4 astrocytoma. Very few people survive. But we don't just say, hey, you got a bad diagnosis. I mean, we're going to, do like Kevorkian and we're going to give you, a death cocktail. We don't do that. I mean, God forbid that medicine gets to the point where the easy choice is the common choice. I mean, is it tough when somebody has an aggressive cancer and tumor? I mean, you're probably going to have surgery, maybe going to have radiation, maybe get chemotherapy. Is that a lot of work? Yeah. But you know what? We also sometimes diagnose babies with conditions in the inside that we just can't fix. And we're human. I mean, we do a lot of really cool stuff, and there's a lot of cool fetal surgery. If you're ever bored, go into YouTube and just look up fetal surgery. But we can't fix everything. It's amazing what we can do and that we couldn't do 20 years ago. I've had 3 patients now that we have diagnosed with lethal anomalies where baby's going to probably survive, through this pregnancy, might die in labor, might pass away right after labor. One was a baby that had anencephaly. Anencephaly is a condition where there really is no brain. The brain and the neural structures pretty much stop here at the ears. There's no forehead, no brain. And the babies move around inside fine, but they don't survive very rarely on the outside. We had another baby that had a condition called trisomy 13. There were lots of heart defects and skeletal defects. And when you looked at it all, it's like, we just can't fix that. And I had a third patient that had a tumor, had a tumor that was coming from the base of the tongue that came out of the mouth and was about half the size of the whole head. And we diagnosed this early in the pregnancy. Our high-risk doctors got involved and we tried to find every option. We found one surgeon in Colorado that was willing to try and fix this. They said, we will give this a shot. We are not real optimistic. Mom knew that. And so the day before she was set to fly out to Denver, she actually broke her bag of water. She broke her bag of water, and of course not. We can't fly her to Denver, and she delivered at our hospital, and the baby didn't even survive labor. But when all 3 of these diagnoses, we sat down with the patients and we said, look, I know this is scary, but we're going to make a promise to you. We're going to be there for you. Not only during your pregnancy, we're going to be there with you during your labor, during your delivery, and we're going to be available as far as physicians and as far as counselors after you deliver the baby. We're going to help you through this. You're not going to go through this by yourself. And the patients, sometimes they were being pressured by their family. Listen, go up to Atlanta and get an abortion on this. You just don't deal with it, start all over again. So all 3, we offered them that kind of physical, emotional, psychological, and spiritual support. And all 3 decided, I want to keep this pregnancy going. I want to see my baby. And all 3 delivered. And I learned a really important lesson on the one that had the huge tumor coming out from the base of the tongue. I mean, it was almost you've probably seen what a placenta looked like. This looked like a huge placenta coming out of the baby's mouth. And absolutely the baby, there was nothing we can do to establish an airway. And even if you were looking through a medical textbook and you saw a picture of this baby with a huge tumor coming out of its mouth, it's just natural to just, lick your finger and flick the page, and you just don't want to dwell on that. And that would almost be a natural response to say, ugh, I just don't want to stare at that. But I learned a real important lesson with this particular patient. She had her family. She had her husband. She had her other daughter in there. She had a sister-in-law, brother-in-law, parents, grandparents. All these people were in the room. I mean, we have rules on how many you can have in the room, but we broke every rule. And then right after the baby was born, and you could see this huge tumor, for the next 7 hours, they passed that baby around. Everybody wanted to hold that baby, kiss that baby, love on that baby. There was something special about that baby. That baby was family, that baby was kin. And I learned a real important lesson, that they saw beyond that tumor coming out of the baby's mouth. And they said, that baby has a tumor, but that baby is part of us. It's part of our family history. It's part of our lineage. And they all wanted to love and hug on that baby. 6 weeks afterwards, with all 3 of those babies, where we knew baby was going to pass away, all 3 of those couples, when we sat down and said, okay, tell us, how did we do? How was this situation and the management, and how could we have been better at what we did to provide you with, you know, the help that we did? And all 3 of them said, you know, we know we could have aborted that baby, but, and the one is a nurse anesthetist, which means she's a nurse that puts people to sleep before they have surgery. And she said, I had felt that baby moving around inside of me. She goes, I just couldn't imagine to feel that baby moving inside of me. Then somebody else puts me to sleep, and then I'm asleep for a half hour. And wake up. So all 3 said that the way that we helped them,
And beyond. Thank you so
you're
much.
it was a pleasure. And if you have any questions for anybody who's out there, you can go to my website. My website's really easy. It's prolifedoc.org. It links you to an email. I'm really good at checking the emails. And if you have questions or situations, again, that website is abortionpillreversal.com. But anything we can do to help educate, you know, you, assist you, you know, and just help serve the preborn. And I really appreciate Rachel using the term preborn. You know, I don't like the term unborn. Reason being, unborn means at this particular time in the pregnancy, they are not born. But preborn means that the normal expectation from this point on is that you're preborn. So the next step is to be born. Just like before you send your child to school, you send them to preschool, because you send them to preschool because the next step is to go to school. You don't send your child to unschool. Before you watch a sporting event, you watch the pregame show, because what's natural after the pregame show? The game. You don't watch the ungame show. So unborn just means at that moment they are unborn. But preborn means, yes, they aren't born yet, but the normal expectation and the natural process is to be born. So thank you for using that term. You still there, Rachel? Well, Rachel, I think it's kind of locked up, but I can still see me moving around.
Can you hear me?
Yep, I can hear you.
Okay. Sorry about that. No. Well, and I don't know where it was at because it was on mute. But, okay.
There you go.
I'm so sorry about that. I don't know what happened. But thank you so much. Thank you so much for sharing not only that we say preborn, but then the purpose behind that, because that it is absolutely so intrinsically needed and important to talk about continually the humanity that child is as much a person as all of us sitting here tonight listening. So thank you so much. And thank you also for sharing those incredible, beautiful stories of those babies who had health conditions and the value that we're worth fighting for. And something that I've thought about is we're worth fighting for, and I know I'm preaching to the choir, but not that we may live, but because we're already alive. So thank you so much.
Absolutely. And if I can help y'all with anything, just let me know. All right. God bless y'all and have a safe weekend. Wash your hands.
Thank you. God bless you.
Bye-bye.
Wow, oh my gosh, I'm so excited that everybody's on the call. This is so awesome. So please, if you guys have any questions for Dr. Lisle, please feel free to text, call. him and his office. He's in Florida. I just wanted to share that. So if you know of any young woman who she may need the abortion pill reversal, or a young woman that her and her family, if they have a little one with a health condition, you can send them to Dr. Lyle. And also Dr. Altman, she's not practicing anymore. She's a retired OBGYN, but she's on this call, and she lives in Florida as well. So shout out to Dr. Altman. Hello. Hi. So our, and also, like, just to sign up, but Dr. Altman, she testifies so for all different pro-life legislation. So if you need someone to testify for pro-life legislation, Dr. Altman, Dr. Caruso, Dr. Monique, Dr. Lyle, any other physician that's on here, please ask them. Okay, our next speaker, and I'm sorry the background noise, that would be my dog. He's mad at me because he wants me to let him into the office to give him food. But our next speaker is Dr. Caruso. And he is a practicing OBGYN in Chicago, Illinois, and he is also such an incredible soul, and he's going to be sharing a bit of his own personal journey. So if you would share a bit more about yourself, Dr. Caruso, and share about your story, that would be wonderful. Thank you so much for your time.
Thank you, Rachel. Can everybody hear me? Can I be heard?
I can hear you.
Oh,
Yeah.
excellent. You never really know about these things until you actually get started. I have no idea how I'm going to follow up from Dr. Lyle. I just don't have as many stories. I just don't. Essentially, I'm an OBGYN who also is subspecialized in reproductive endocrinology. When I went into reproductive endocrinology, I thought I was really going to be doing something special for women, because there is nothing more stressful than a couple who cannot conceive. They go through life thinking that they are going to be parents. They get married with the expectation that when they're ready, they can start, and it'll be almost automatic that they will conceive. But when that doesn't happen, then all the problems begin. And going into reproductive medicine, I thought that basically I could help them, focusing on what the outcome would be, which is a baby. And a lot of people think about it from that perspective. I mean, no one ever really thinks about how they get there. They just see the baby at the end of the thing. So I'm sort of at the other end of the file as Dr. Lyle is, but we'll get to that in a minute. So I came to Chicago for medical school, went to Springfield and got trained, then came back with a wife who told me I couldn't leave Chicago, and went and did her fellowship in Rush, and then went into private practice, reproductive endocrinology in Northwest Indiana. And for 16 years, I helped people get pregnant. I never really thought twice about what we were doing or how we were doing it. At the end of the day, they were either pregnant or they were not pregnant. And then at the peak of my career, I actually joined the faculty at the University of Chicago. And while I was there, I started seeing things that I really didn't expect, and really started to give me a lot of pause about people. When you start thinking about the people building families, then you start to think about all kinds of different people trying to build families. And while I could give you story after story after story, I think it's better off if I just let your imaginations run wild. And then basically what happened to me is I had a reversion to the Catholic faith. My wife had lost her father and had gone to Italy to basically what she calls the main event place, and saw things there that changed her world, which she brought back to me. And we went to a priest who basically started talking to us about what we were doing and how we could basically be better. And almost overnight, what I was doing turned into something that was different than what I had ever thought of before. So what happened was, doing IVF, doing embryo transfers, doing any of the things that happen in the process of in vitro fertilization, I started praying for the babies that we were transferring. They suddenly didn't become preborn. They became babies to me. And we started to really kind of think about what we were doing I was at least, about what was happening as we were putting these babies in, how many were lost, I started looking at the babies that we threw away, the embryos which we discarded, as abortions. So all that kind of, went into that field. And then I got called up by one of the local parishes, and we were going to be fighting the building of a large fertility center in one of the western suburbs of Chicago. And they asked me to speak, and I had no idea what I was going to talk about. So I wound up giving what I would say the infertility 101 thing that I've been giving for 16 years. And it's one thing when you talk to a bunch of people who are trying to get pregnant about these things, and another one entirely different when you talk to a group of people who had no trouble having children. When you take down I guess I would say the curtain from behind the lab, and you start showing people how the process actually starts from beginning to end, these people who were watching this were absolutely horrified. To them, it looked like Frankenstein's lair. It looked like we were doing things that were truly something out of Brave New World. And they were horrified. And then when I showed them that basically when we were doing IVF and transferring multiple embryos and sometimes causing a multiple pregnancy, how sometimes the women looked to have a reduction in these pregnancies, which we euphemistically called a selective reduction, and how they would go forward and have a single baby, an embryo localized on ultrasound, and then a needle placed through the uterus into the actual sac of the baby, and then injected with saline and killing the baby inside, which sometimes led to the full loss of the pregnancy. They were horrified, and we worked very hard. We failed in our efforts to stop the clinic, but we forced them to at least change the name of the clinic. When I left the University of Chicago, which was actually more because of budget cuts than anything else, I was trying to figure out the best way to transfer myself back into the primary field of OBGYN. And so I did some work for one of the local hospitals as a hospitalist, and helped with babies and helped deliver babies, helped with C-sections, helped to monitor the babies in the labor and delivery suite, and had my crack at 4 medical students from one of the local Catholic medical schools in Chicago every 6 weeks, where we would talk about different things. And as they would bring up things about contraception, as they would think about things about infertility, I was able to give them, because of my background, alternatives. And honestly, I thought that maybe I would get a lot of pushback, but you'd be surprised when you talk to people in the know about different alternatives to help with bleeding, and help with pain, and help with endometriosis, and help with preventing pregnancy or spacing children or whatever, that didn't involve using artificial means, that they tended to respond very positively. And so for a while, I started going out and talking about the whole in vitro fertilization process in the community. But that's a more difficult line to talk about than abortion itself. I mean, when you think about what people in the reproductive endocrinology field do, it's really, when you again, if you're focusing on the outcome of the babies alone, you don't really see what's wrong. You don't see that what you've done is you have completely separated the male and the female. The woman comes in 6-7 times during the course of the preparation for this, for ultrasounds and blood testing, to see if she's getting closer and closer to the time that we can actually get the eggs out. The husband doesn't have to be present at all, and most times is not. And so when they go back to get the retrieval of the eggs, that's a surgical procedure, and the husband is not really there for that one either. And so you do an ultrasound, you place a needle into the little cysts, you drag out all the fluid, it's taken to an embryologist who finds the eggs. The husband separately goes and produces his own sample, which is then used for the fertilization process. Once we know the embryos are ready to transfer, there's still that scenario going forward where you only have an embryo going back into the uterus, usually without the husband present. So whether you only have one embryo whether you stimulate the embryo, whether you do natural IVF, they just get the one follicle that's made every month, you are still separating the male and female. In natural law, in the natural law that we say, children come from the union of man and woman. Once that man and woman have been separated, you can do anything you want. So if you basically just collect the sperm separately, now you can take the sperm and put it anywhere. You can put it in the fallopian tubes. You can put it in a dish with embryos. You can put it in a dish in somebody else's eggs. You can do anything with them. And that's where that process kind of falls apart. So now I, like Dr. Lyle, I'm a pro-life OBGYN. I don't give contraception. I don't do abortions. I don't refer for abortions. I don't actually refer for IVF either. I do infertility treatments. I do more natural forms of stimulation, and I actually still use the medications I used before. But within the time of time what I call the ovulatory window, I ask them to be intimate with each other. Now, what I find is, honestly, you doing those procedures that way, I don't get the results of in vitro fertilization, but I certainly do have enough positives that I keep my practice busy. I, like Dr. Lyle, am one of the APR physicians in Chicago. As we get together and talk about these things, I found out quite by accident, and God help me, that I'm actually one of the busiest APR physicians in the country. I answer 7 to 8 calls from women who are seeking to reverse their abortions every month. And unfortunately, because they come from the entire Chicagoland area, I very rarely get a chance to actually see them. So I only get reports from the crisis pregnancy centers that see them, because I usually send them there to see what happens to them. But we have an excellent success rate with that as well. The one thing that I talk a lot about is what happens to the extra embryos that are present. Now, when you do in vitro fertilization, you basically get as many eggs out from the woman as you can get, and you use those to try to create embryos. And when the embryos are created, a proportion of them go back into the uterus. And these days, because they're all trying to make they're trying to limit the size of the pregnancy, limit the number of embryos that actually be plants, they will only transfer one embryo. What will happen with the rest of them is they will either freeze them, or if they don't reach the stage that they need to, they will discard them. And what in those cases, you have a scenario where once they're frozen and the woman has had the number of children she's happy with, those embryos are abandoned. Yearly, the center will contact them to see if they can pay for a storage. But I know on good effect that there isn't been a single embryo in the United States that's ever been destroyed because of non-payment of storage. So the numbers that we know of how many embryos exist in the freezer, they number in the millions in this United States. So the thing is, then what do you do with those embryos? I mean, you can't really transfer them into because the woman who owns those is not necessarily going to release them. And if they do release them, then they're available potentially for adoption. But again, adoption has the same problem as the in vitro fertilization itself, because it takes off and removes the actual union of the man and woman to actually create the pregnancy. So that's the concern. Now, Dr. Lyle talked about the pre-implantation genetic diagnosis, using something called, oh no, he didn't talk about that. He talked about NIPT, which is finding the cells of the baby in the mother's circulation and then testing those for genetic information. And now there are new tests that actually will test it for cystic fibrosis and maybe even get the actual blood type of the baby just from the cells around that are circulating in the bloodstream. But pre-implantation genetic diagnosis is taking the embryos as they develop and taking a cell from the embryo and testing it for genetic abnormalities. Now, what Dr. Lyle didn't tell you about NIPT is that the vast majority of people who do NIPT who have an abnormal baby will abort their child. And I have a woman who did it twice, who went through and found the NIPT to have a trisomy 7, which is one of those very unusual genetic terms, so unusual that the genetic counselors had to actually go back to their books to find out what kind of impact it would have. And they found that it could be anything from mildly affected to normal, and they aborted that child. The second time, she wound up having a normal NIPT, and then went to the high-risk docs who did an amniocentesis, where they put a needle in the abdomen to take some of the fluid from around the baby to check cells that come directly from the baby. And those cells showed the baby had trisomy 21, or at least was a mosaic, had some of one and some normal. And they chose to abort that child at 17 weeks. And that baby, morphologically, was normal in pathology. So the question is, was the baby really affected at all? But in pre-implantation genetics, what happens is we find embryos that come up in 3 different ways. They either come up normal, they come up abnormal, or they come up undeterminate. The normal embryos are usually the ones that are transferred, whether it's normal overall or boy or girl or whatever whatever the patient wants. Those are the embryos that are transferred. The abnormal ones and the ones that we don't know are both discarded. And see, these things are all the scenario that we have to kind of think about, because you are throwing away embryos that used to be seen and actually put in patients' uteruses and create pregnancies. When I was first in training back in 1992, 1993, 1994, 95, we were transferring embryos that were just only 1 or 2 days old. Now, the pregnancy rates weren't 50%, but they were about the same as they are now, between 20 and 30%. These embryos now, if they're found on day 2 or day 3 of culture, are discarded now. They're not good enough for transfer, because we take all the embryos and try to grow them to the 5th day, which is the day that the embryos are actually naturally present inside the uterus. And that makes it, then they fall off and die. And again, every one of those embryos in the past have been transferred into a uterus and created a pregnancy. That's not, and IVF pregnancies, now we can go over this all day. IVF pregnancies, now I'm on the other side. I see IVF pregnancies and I see the complications that we used to poo-poo on my side of the aisle. I see the early labors. I see the small babies. I see the too much fluid, too little fluid. I see the complications of multiple pregnancy. And I know that these embryos, these babies are going to be normal babies and be fine, but there's certainly embryos in pregnancies that are more difficult than the average pregnancy. Then you have the issue back to the frozen embryos. When I talk about these, I call them the Budoi. The Budoi were the Amerasian children of the Vietnam War that the Vietnam women didn't want and the Americans didn't want either. And the problem with those embryos is that the women who create them don't want them because they've completed their family, and there's nobody who will take them because they're not releasing them to any place else. Now, there are places that actually do collect these embryos. They're called Snowflake or whatever, that take them. But remember, when the embryos are transferred, they transfer the best embryos they possibly can. So while the embryos that are left might cause a pregnancy, they are not as likely as the ones that were initially transferred. And so those can be actually picked up by somebody who's going through a transfer and go from there. Now we can actually freeze your eggs. So you're 22 years old and you think that you're not going to want to have a baby till you're 45 years old. You can take your eggs and freeze them. Now, there are a growing number of pregnancies across the world that are created with these embryos. But again, just think about what is going on in these couples. You have a woman who is a young woman who thinks she's thinking about the future for her family, but has basically told her not yet met husband that when they're going to have a child, they're not going to do it together in the marital embrace. That it's going to be done by him depositing a sample, trying to fertilize an egg, which is then transferred back into her uterus. And you see what it does is it breaks down that bond. I have seen patients who have not gotten pregnant with guy A, who 6 months later come back with guy B. I have seen women who come in with bags of money to put it down on the table because they want to use their siblings or their friend's uterus as the vessel that carries the baby. I've seen same gender couples that want to normalize their relationship by basically doing the most amazingly different combinations of things you possibly made. An egg from this friend, the male part from this guy, then placed in the uterus of woman number 2. It's basically a scenario where we now can shuffle up the gametes like cards and just place any 2 cards down and get a baby out of that. But nobody ever thinks about it. And of the things that we talk about, whether we talk about abortion reversal, the abortion itself, the dangers of contraception, whatever, this is the subject that's the hardest to discuss, because we don't think about the process that it takes to get the baby to the mom and born. We think only of the outcome going forward. Dr. Lyle actually very nicely talked about an IVF pregnancy that came to him and talking about his use of progesterone. And I am a big fan of progesterone. I'm a hormone nerd. I throw progesterone all over the time. I mean, no problem with me. I'll give women progesterone until they're dizzy, because I know that helps an early pregnancy continue to grow. But the IVF patient who comes to a doctor is not having her own cycle. It has been completely taken over by the doctors who are doing the procedure. We stop the woman's ovulation. She will not ovulate on their own. Then we give other medicines that actually make the eggs develop. And then we give a third set of of hormones to maintain the uterus through the remainder of the cycle and into the first trimester of the uterus. It's not unusual for the doctor who gets an IVF patient back to get like a instruction booklet of what to do about the hormones that they're on, because they're not just on progesterone. They've been placed on estrogen to maintain the endometrial lining. They've put on steroids to try to relax relax inflammation inside. They're placed on a baby aspirin to kind of ward off the possibility of problems going forward. They're put on maybe maybe they put on a vitamin of a certain type because they want to make sure that they're making enough of a certain B vitamin. And then what has to happen is by the end of the first trimester, the vast majority of these hormones are gone. You don't need them anymore, because realistically, by the time the baby gets through the first 12 weeks, it's really sort of on its own. I mean, it's completely independent. It'll survive based on the hormones it creates in the placenta and the nutrition that's provided to it by mother. And it's just going to grow. But that first 12 weeks is the most important part of this, the send-off for the baby, because if the baby doesn't get that promotion from the time that it's implanted all the way through to the point of the 12th week, then the baby is not going to make it because of the complete artificial means by which it was created. So, I mean, I think that's basically where we are now. I mean, I enjoy I've never had more enjoyment as I have now last 7 years I've done this. I've delivered, I haven't delivered 4,000 babies. I've delivered about 1,000 babies, but taking care of people and now being able to kind of help people get pregnant and then actually deliver their babies is like the most amazing thing I've ever seen, because I can close that circle. A couple who basically prayed for a baby, went through the process and actually created a baby with God's love through the marital embrace, who then gets through that first trimester. We watch them change into a pregnant woman and a pregnant couple and then deliver a blessed baby is just the most amazing thing in the entire world. And honestly, I think about it, I don't really do a whole lot of work with the actual abortion movement. I have done some work with them, and I've told the people there that, I mean, it's not that I don't support it, I really do, but the other things take up a lot of my time right now. But I will say this much. Knowing what I know about the early pregnancy and what happens in the women who are trying so hard to have babies, it mystifies me to no end how a woman who could get pregnant on her own would want to destroy that pregnancy. It just doesn't make any sense to me, because there is nothing more wonderful and blessed. I'll tell women all the time that women are God's most perfect creation, not just because I'm male, but because they can do things that men can't do. This whole idea that they can actually gestate a baby, deliver a baby, and in 6 weeks' time be almost back to pre-pregnant size, shape, and ready to roll is just a miracle to me. And for someone to go through that process and get pregnant and then do something to try to harm that child just completely mystifies me. I mean, I really think blessed. I get to help out with 4 different crisis pregnancy centers, 3 in Illinois and 1 in Virginia. And I look at their ultrasounds and I see what's happening in these early pregnancies. And I know that these women who are coming to these people are doing it because they want to have help to actually have these children and become mothers themselves. And I think that that is the most beautiful thing in the world. So would I ever go back to the life that I had before? Not until I could figure out, or unless I could figure out that there is some major benefit that occurs in removing the marital act between 2 people. I mean, what else is marriage if not for the begetting and maintaining of a family? Whether it's a natural family that's created through the marital bond, or an adoptive family that's come from adopting children, I think that that's the most beautiful nuclear thing that can possibly happen. With that, I think I'm going to just open it up to questions.
Okay, Dr. Caruso, I cannot get my video on. I'm sorry. Thank you so much for your time. Thank you so much for sharing your story. Something I also so appreciate, you know, like with you and also with Dr. Lyle, and I know with Dr. Monique too, is thank you guys for showing the humanity of these babies in IVF with the health conditions, regardless of any of that, the recognition that we are all persons made in God's image and we are deserving of protection. So thank you so much.
You're welcome.
Thank you. Okay, there are a few questions for you.
I always have questions. Thank you so much, Dr. Caruso. That was extremely inspiring, especially your humility in showing that you can adjust your mode of practice as you learn more about what good medicine and ethics really are. So we really admire and appreciate you. I just was wondering if you could say more about how you're able to help pregnancy centers across states, and if you could talk about the Virginia Center, because our program operates in Virginia and Georgia, and we'd love to know more about that, and just more about inspiring doctors to be able to help pregnancy centers, because that's a real need.
Well, I was asked very early on when I first came to, I call it the reversion or whatever, that reached out to me. I had a number of centers in Chicago that I got involved with, and then one day, completely out of the blue, the executive director of this Virginia center called Hope for Life actually reached out to me And their big thing, I think they were interested because one of the centers I had a van, and they have a van, and they were interested in the medical director stuff. And because you can be a medical director anywhere as long as you basically can read their ultrasounds, I guess, and review their policies at some point. So that's how that happened. And so what happens is they have somebody locally who does their policies. I don't know why they don't read the ultrasounds. I just don't know. And they send the ultrasounds to me. And the way in which it's done now, I don't know what the centers you're involved in, but they all use a computerized thing. So they send me a message that their ultrasound's ready. I log into the website. I can pull up the ultrasounds and see from there. Now, as far as inspiring other doctors to be involved with crisis pregnancy centers, I pray for that every single day. But you see, I don't know what's going on in like South Carolina or Virginia or any place else, but I will tell you in Illinois, the centers are being, I don't know if it's too strong of a word to say attacked. I don't know, but they're being attacked. And even before that happened, I got a call from the state one time, 5 or 6 years ago, that one of the centers I've been involved in had a report against it. And I said, I didn't know anything about it. And they said, well, you need to know something about it. I said, well, why? I said, because don't you realize that they operate on your license? Which is very true. And I think a lot of doctors are very worried about the fact that my license and my malpractice insurance have to basically cover what the activities are there. And what I do for that is I choose to take a direct approach to how they're doing things, because I always want them to be above reproach. So I think what you have to do is locate what the most any pro-life doctor you can find. And other things that I do right now, I got myself involved in the Catholic Medical Association. And right now I'm trying to instill more membership. And one of the reasons that I would like to get more members in there is because the more members that come in and can see that it's safe, the water's safe, the more people we can get to kind of volunteer for centers like the ones that you're in Virginia and try to get the best care they possibly can. And I suppose they reached out to me because they couldn't find anybody local. And that's why.
Thank you so much. And if I may be so bold as to ask a second question, I just wanted to know how I can explain to friends. I agree with you 100%, even though I'm not Catholic, but a lot of my fellow Protestant friends feel that the good of the baby outweighs the bad of separating the marital act. So they are more comfortable with something like natural cycle IVF, where you're not creating extra embryos and you're not genetically testing. And so they make all these excuses and say, okay, we can do it in this way, and that's moral. So what would be your response to that?
Well, the first IVF was natural IVF. When I was at the University of Chicago, I did a number of things. And one of the things I did is I actually created and found and copied and collated the entire IVF story, which starts sometime in the 1950s. But it's still, you can't get past, no matter whether you make one embryo or 5 embryos, the fact that the actual egg it has to be retrieved and pulled out and separated from the marital act. There is a procedure that's called a low oocyte transfer that was tried on baboons years ago, and they got almost all the baboons pregnant in the report. It's been tried a couple times in humans. I actually did a series of about 12 a couple years ago, but no one got pregnant. And what that happens is, how that works is you get the egg out and you put it back into the tube, and then they have relations. And the goal is that the egg and sperm meet in the fallopian tube and create a pregnancy. But that marital act is still intact. We had some perfect cycles, and we just could not create. There was never a conception. Now, of those 12, 3 got pregnant in the next cycle on their own, which is crazy, but crazy, praise God. But I know that I have a number of Protestant friends who feel the same way, and trying to help them through by natural means is probably the best thing we can do. There's a big part in my generation of reproductive endocrinology. We were taught surgery. So doing things like tubal repairs and adhesion, lysis of adhesions, and creating a better environment for a pregnancy to occur. Those are all in my line of things that I can offer people. The modern reproductive endocrinologist is not trained in those things, so that stuff has been lost in translation, because IVF became the centerpiece of everything. That field is actually moving towards natural IVF because they're really fearful of multiple pregnancy. So, but unfortunately, I can't tell you that it's any better than the actual full thing. Sorry.
Thank you so much, Dr. Caruso. Okay, we have a question from Dr. Abraham, and she was, I heard she was invited by Dr. Monique, and she just heard about APR, and hold on, I'm trying to find her question. I want to make sure I ask it
Okay.
exactly as she asked. Hold on. Hold on. It's like it's right there, and I can't find it. I think she was wanting to ask, she was asking, she was asking where does she get trained to do APR?
Oh.
I mean, and I know that it's, like something that's, sorry, go.
Go ahead. That's a very good question. If you Google the APR people, the centerpiece of this is in California with a doctor by the name of Dr. George Delgado. And they're if you reach out to them, and I think you can get their email off the website. If not, I can take a look and see if I can find it for you. They will be more than happy. It's not necessarily a training in the sense you have to go for like a class. It's a training where they have a series of handouts and maybe slide sets that actually can help you through this. I mean, believe it or not, it's really not that complicated. What you do is you get the phone call, you get the information on the potential save patient. You call them, tell them that you're going to send in a prescription, call the prescription into the local pharmacy, and then you just have to follow up in a few days. The only challenge is actually the pharmacy, because I don't have any pharmacies that when I call that the person on the other end says, I'm going to pay for this, and then go hug the patient. Okay. As a matter of fact,
Fair stories.
Yeah, I mean, as a matter of fact, I have to be very careful how I actually make the actual prescription, because if I order it the way that it should go, they will not fill it. So I have to give very big instructions to the client about how to take the medication, because the prescription is going to say something different. Now that's just where I am. Like, I know that people like in Tennessee and people in, where else did I hear people? Oh, in Utah, they can just say that they can just give that prescription and fill it the way it's supposed to go, and they'll take it. But in Illinois, I have universal problems when I call in and ask for 2 pills twice a day. But if you just get in touch with Dr. Delgado at the APR hotline, they can definitely get you. They're very, very responsive.
Thank you so much for answering that.
And I'd love to have her on board, to be honest with you.
Absolutely. Thank you, Dr. Abraham, for such a wonderful question. That is really phenomenal, because it is. Oh. Okay. Like something I've been learning about, just, as constantly, I mean, probably since I was 13, doing really just medical ethics research, and just finding information about APR, IVF, just the gamut, all sorts of types of information for prenatal diagnoses. And something that I'd heard is the lack of physicians that are doing APR. And so my understanding, but please, physicians, correct me if I'm wrong, but my understanding is that there's a lack of physicians who do APR, and there are more women who are wanting APR, but not as many physicians doing it. Am I correct on that?
Doing APR?
Yes.
Yeah, as Dr. Lau said, it's not just physicians. There's nurse practitioners, there's physician assistants. One of the places that I actually work with is one of the crisis pregnancy centers that I am is signed up with them, and I get a call from a nurse there as well. So I get called from the national hotline, and I get calls from the one crisis pregnancy center as well. See, the biggest problem is I really, one of the other things I pray is the pro-life movement to grow, and that OBGYNs would truly start to realize that what they're doing is taking care of two patients, mom and baby, from the time that the woman conceives until she delivers the baby.
Great.
As I think I've said before, 10, 15 years ago, there was an entirely new movement in the American College that was more like promoting pregnancy termination than trying to find new ways to maintain a pregnancy. And so there's a generation of physicians that's coming out now that really don't have any desire to do APR. And trying to get them, is it possible? Sure, I'm living proof of that. But it's not, I don't know how possible it is to be to be a person who's going to stand up and take what sometimes is not exactly a pretty position and start to do APR. You know what I mean?
I absolutely understand.
So what I've always said is Dr. Lyle, myself, there's that you could talk to the guys in Utah, you can call up Dr. Delgado. We are more than happy to help, lend a helping hand, give a pat on the back, to try to help people along with going forward, because this is not easy. It's not easy to, I can't say enough how much I love the ebullience of Dr. Lyle. That I just wish I could be like that. I mean, but the thing is that it's not the easiest thing to do every day. And I think if Dr. Lyle was still on the call, he would agree with me that every day is going to be a new challenge. Every day is going to be somebody who's going to basically do something that you don't agree with. So every day is going to be something that you see that you have to have a response to, and you have to measure your response, because if you are too strong, then they're not going to put it up there. And if you're not strong enough, then people are going to think you've sold out. So it's very, very hard to kind of maintain that middle ground all the time.
That is very well said. Thank you for sharing. Do we have any other questions from anyone? You don't have to write it in the chat box if you just want to unmute yourself.
This is Valerie. I have a question. Some pregnancy centers do not do same-day ultrasounds, and one reason I've been told is that the medical director doesn't allow it, and I was just curious your perspective on that.
I'm not sure. I mean, I'm not one of those medical directors. I think it's really the situation that they want to make sure that the patient is, okay, the great fear is that a woman's going to come in, get the ultrasound, and then take the ultrasound picture back across the street to Planned Parenthood, because the Crisis Pregnancy Center doesn't charge for the ultrasound, but Planned Parenthood does. In the next move over that I'm trying to do with my crisis pregnancy centers, I want them to stop measuring the babies, because I'm trying to keep them with a limited ultrasound, and gestational age is sort of like a actual ultrasound. So I think that's probably why. I can't think of any other reason why they would want to have the woman delay having the ultrasound.
Okay, so in other words, they take the ultrasound they get at the pregnancy center and then take it to Planned Parenthood for the abortion?
Correct. I mean, the Planned Parenthood, if they're going to do a surgical abortion, needs to know the baby is beyond like 8 weeks. So they can actually get tissue or whatever, however, I don't even know what they do, but to be able to do that. And what they do when you go in there is they'll do an ultrasound, but I think they charge you like $400 or something. So they know, and sometimes they will actually tell them if you go next door to the crisis pregnancy center, because there are a number of places there are crisis pregnancy centers like across the street from the Planned Parenthood. And you can go over there, get your ultrasound, just bring it back to us and we'll take it as gospel.
Okay, thanks. That's very interesting. I hadn't heard that before. That's helpful.
Is that what you'd recommend though, Dr. Caruso? If you were running a pregnancy center, it seems like we would lose some of these mothers that we could otherwise convince to choose life.
In terms of in terms of waiting to do the ultrasound?
Right. It seems like sometimes we just have that one opportunity, and if we make her come back a week later, she doesn't come back, and we've lost the voice.
Yeah.
I said I am not one of those medical directors. I think that I agree with you, Mark. I think there is only one opportunity we get with these women to get them in, to get the ultrasound, to get the counseling started, to get everything in place that these crisis pregnancy centers do. Remember, they do much more than just do ultrasounds.
Yeah.
And if we can get all their services already put in as soon as they can, we can prevent them from ever going back across the street. And that's what my goal is to get them. I agree with you.
Thank you.
Thank you all so much for your questions and for your time. Thank you guys so much. Okay, so our next speaker, I'm very excited to introduce her. I'm excited to introduce everybody. But I met Dr. Monique 3, 4, 5, feels like forever, years ago. And she is just a really special, sweet friend. And so she will be sharing about the natural fertility methods to be able to help these precious parents who they're saying, I'm not going to do IVF, but what do I do? So if you would share that, Dr. Monique, she has her own practice in Philadelphia. Dr. Caruso has his own practice remind me, Dr. Caruso, in what area of Illinois? Oh, hold on. Oh, sorry, he's on mute. Could you share, Dr. Caruso, the area that you practice in Illinois? Oh, he's on mute. It's Downers Grove, I believe.
It's actually Woodridge.
Oh, sorry about that. Sorry. Okay, Woodridge. Okay, Dr. Monique, would you share, please?
All right, sorry. Problems unmuting myself.
Oh,
so,
and Dr. Monique, I'm totally interrupting you, but I just have to tell you, Thea's parents are on the call.
Oh, yay! How awesome! Welcome, Thea's parents. For those of you who don't know, Thea is a really unbelievable, amazing little baby, and I had the pleasure and privilege of walking kind of right behind Rachel and giving her prayer support and love and just a few little thoughts along the way as she was completely ministering to this family and moving heaven and earth to help save the life of this child. So excited every time I hear about Thea.
So much advice. Thank you so much. I was like, Dr. Monique, what would you do? I need your help right now. Like, help. So thank you. You did so much.
So my name is Dr. Monique Ribeiro. I am a pro-life OBGYN, and I am so blessed to be that. I am super excited to be on this call. It's not often that I get to have a conversation or follow other pro-life OBGYNs in conversation. So I was super honored to be here with both of you, Dr. Crusoe and Dr. Lyle. I also was a complete cafeteria Catholic, went through my residency training, worked as a typical OBGYN for many years. And then my marriage completely collapsed, and God stepped in and completely renewed it. And through that renewal, I felt like I needed to do something to pay God back. And that took me to praying outside of an abortion center, which I thought would be kind of a one and done instance. But on that day, God put into place everything that was necessary to bring about a complete drastic change in my entire life. And on that day, I was introduced to somebody who gave me a book about NAPRO technology, which I had never heard of in my life. And at that point in time, I had made a decision that I was going to leave Philadelphia, move back to Texas, and get a job in Texas. But as things unfolded, it turned out that God had plans for me to stay on in Philadelphia, to learn NAPRO technology, to learn how to practice in a completely different way, to stop writing contraceptives, to completely practice according to my faith. And he just completely blessed my marriage, my family, and helped me to become a leader in the pro-life community here in Philadelphia. So currently I co-lead the 2 downtown 40 Days for Life outreaches, and I own my practice, Natural Women's Health. I minister to women within the practice. I also do coaching appointments for women internationally to offer insights about how they can utilize NAPRO technology for their own health and well-being. So it's been quite a ride, and I'm so excited to share with you. In the past, before I learned about NAPRO technology, when I would encounter women who are dealing with infertility or difficulty conceiving or difficulty maintaining pregnancies, because I knew nothing about how to practice medicine and gynecology outside of what I was taught in residency at that time, my go-to would be to send people to the really nice IVF doc who was, you know, in our neighborhood and who would always bring us cookies and pens. And I would send patients to him. I'd get back these lovely notes when they would conceive, and then I would kind of go on to take care of these pregnancies. When I learned about NAPRO technology, at that time, for the first time, I really began to allow myself to understand what was happening with contraceptives, what was happening with IVF, what was happening, you know, in the majority of the treatments that I was using for all of my patients. And being able to practice in a completely different way was just so amazing, to know that what I did every day in my office would not put me in a position that I would feel the need to go to confession that day. It's just absolutely priceless. So what do we do for our patients who are coming to us that are having difficulty conceiving? So the first thing that I always do with my patients is I talk to them. I find out, you know, what is your health history? What are your periods like? What is the length of your cycle? What is your bleeding pattern like? Do you have premenstrual spotting? Do you have tail and brown bleeding? Do you have very heavy bleeding? Do you have very light bleeding? Do you have 32-day cycles? Do you have 26-day cycles? Do you have cycles that range and vary between the two? Do you have any other signs or symptoms? Do you have hair growth on your chin? Do you have hair growth around your nipples? Do you have hair growth on your abdomen? Do you have a lot of fatigue? Do you have tiredness? And all of these signs and symptoms that we can collect just through a conversation, which is what we're taught, you know, when we're going through medical school, to have a history, a really well-rounded history. All of those things lead me into different directions. There are certain kind of blanket tests that I do for patients when they first come to me. I have them learn to chart their cycles with one method or another. I always prefer Crichton Fertility Care Natural Family Planning charting because I find that it is the most detailed and everybody is using the same language. So there's no confusion as to trying to determine the quality of one's mucus or the exact type of bleeding, because people are taught to really be detail oriented and to document appropriately, so that the physician who's helping them can have a really good understanding of exactly what is going on. So I have people chart with Crichton, and then as soon as they can, typically if they can chart 2 cycles and come back to me, that would be fantastic. During that time, I have them get a baseline ultrasound on day 5 to 7 of the cycle. And a lot of people will say, well, why does it have to be on day 5 to 7 of the cycle? Day 5 to 7 of the cycle is the very beginning of the cycle. So at that time, the inner lining of the uterus is very thin. And if there are any fibroids pushing into the cavity, or if there are polyps that are present, then you're going to notice a thickness in that lining, rather than checking an ultrasound mid-cycle and not really being able to determine whether that thickness is normal or abnormal. It also gives the opportunity to look at the ovaries when they're at their quietest stage. So you should not be seeing any ovarian cysts at that time. If you see ovarian cysts, then you know that the prior ovulation was not a completely successful ovulation, and that everything has not completely settled from the cycle before. So we check that early ultrasound. We check polycystic ovarian syndrome lab panel, which gives us a look at not just whether or not a patient has PCOS, but it looks at initial thyroid function. It looks at prolactin levels. It looks at adrenal function. It looks at markers for possible congenital adrenal hyperplasia. And all of that just kind of gives us a smattering of labs that help us to kind of guide our direction. If somebody comes back and they have a TSH level that is still within the normal range, because the range is super, super wide, but say it's just above 2.5, then I usually will ask them to go a little bit further, and I'll look for thyroid antibodies. And it's really interesting because quite often people who have cycle lengths that are a little bit longer, over 30 days, and have just a mildly, still within the normal range, but just a TSH that's over 2.5, oftentimes we'll find that they actually have thyroid antibodies. And just dealing with a lot of natural medicine, dealing with a lot of naturopaths, people who work with natural medicine, and doing a lot of research into this just through reading and through listening, talking to other NAPRO docs, what I've learned is that you can use myo-inositol selenium combination to reduce those thyroid antibodies and to boost the natural thyroid function. So for some people, a part of the issue of conceiving may just be as simple as helping them to normalize their thyroid and to eliminate some of that inflammation that's caused by the thyroid antibodies working on their thyroid. When we find people with PCOS, then we always will look a little bit further and see, do they have any signs of insulin resistance? And do they have issues with a very high testosterone level, which is typical of PCOS patients? And do they have issues with lower levels of progesterone? And typically giving these patients progesterone at the right time in the cycle will help them to cycle back and have tighter, shorter cycles and more frequent cycles than what they're used to, which is great because that gives them more opportunities to ovulate. Then we would use myo-inositol, which is a really lovely supplement that you can use in patients that have higher levels of androgens. If you use it kind of across the board for all fertility patients, it might do a little bit of a disservice to some of them if they don't have higher levels of androgens, because it would reduce the androgen levels. And if you cause too much of an imbalance, even if you drop things too much, then it can cause issues with fertility too. But typically PCOS patients have higher levels of androgens. They have issues sometimes with insulin resistance, and they have issues with lower levels of progesterone. So myo-inositol for these patients, as well as progesterone to help them cycle. then, if somebody has elevated prolactin levels, then if they have any issues with headaches or with visual changes, definitely I would send them for an MRI. We'd look for prolactinoma. One natural treatment that we found with patients who have elevated prolactin levels is the use of Chaste or Vitex. And by using that, you can actually reduce the prolactin levels. But once again, oftentimes people will say, hey, anybody that has issues with irregular cycles should be on Vitex. But if somebody has normal prolactin levels and you reduce your prolactin levels too much, then that can also cause issues with other levels, your LH and your FSH rising too quickly and having a very early release of eggs that are not mature and won't create a healthy pregnancy either. So checking these labs on day 3 is just really useful to have a baseline understanding of what's going on. If somebody has low DHEA, then there are things that you could do to help them to boost that as well. So then getting past that, the next thing is, you're having these patients chart their cycles and to look at their bleeding patterns to identify things about what they have charted on these cycles. So if somebody has persistent premenstrual spotting and they give you a history of painful periods, it's very likely that they have endometriosis. And if somebody has endometriosis, they tend to have higher levels of inflammation as well. So with endometriosis, you want to initially look at, are there any supplements that you can use to help these patients with endometriosis to reduce the inflammation, reduce the pain? And one of them is N-acetylcysteine. And there's a really great little protocol that's been used. There's been NIH studies done with it where women with very severe endometriosis have been given these protocols. And they have seen an actual reduction in the number of endometriosis implants or the size of the endometriomas, which is endometriosis within an ovarian cyst. Those have decreased and the patient's pain has improved drastically. And N-acetylcysteine is one of those supplements that you can use in pregnancy, so it's a good thing. So you could do that and see if you get an improved chance of pregnancy and if the pain is significantly improved. And if you've exhausted all of the other things with that patient, and this is the one thing that you keep coming back to as far as the possibility of endometriosis, then you can ultimately look at doing a laparoscopy for that patient. And I always refer to, I'm trained in NAPR technology medically, and so I do a lot of the management medically, but although I am a gynecologist and a surgeon, I have not been trained in NAPR technology with the year-long surgical fellowship. So I would typically, because we have a few people in our vicinity who have been trained in that way, I would refer endometriosis patients to them. So currently, Dr. Christine Hemphill in Camp Hill, PA, is the person that I would refer to. And we would send them specifically to them because typically a gynecologist who is addressing endometriosis surgically will just go in and burn the lesions. And burning the lesions will give you temporary relief, but it won't eliminate the problem permanently. So Dr. Hemphill would go in and actually remove the lesions. And it's more restorative to do it that way. So she's been trained to do that. And that is just one amazing thing. I mean, you can look at a chart for someone with Crichton Fertility Care Natural Family Planning charting and just finding that placement of premenstrual spotting in combination with the painful periods would tip you off to look for endometriosis. Same thing with tail end brown bleeding at the end of your bleeding patterns. So if someone has persistent tail end brown bleeding, and they have a history of PMS symptoms, and they have a history of shortened cycles, we would automatically think of lower levels of progesterone. And it's impossible to maintain a pregnancy unless you have adequate amounts of progesterone. Just like when we're doing abortion pill reversal, the whole purpose of giving progesterone is because the abortion pill, the RU486, blocks progesterone from getting to the baby. And so our goal in giving progesterone is to overwhelm those receptors and to provide adequate amounts of progesterone for that child. And so, and similarly, when somebody has lower levels of progesterone at the, that shows within that Crichton charting, that shows within blood testing, then you can supplement back with progesterone at the correct time following ovulation. You don't want to give progesterone at any time during the cycle. You always want to give it at the correct time, because otherwise you'll actually end up doing the patient a disservice and messing up their cycles. Next, we move on to, the patient should have a few dry days, and then they should have mucus findings. So the quality of the mucus is super, super important, because the mucus is the highway for the sperm. So if you have very little mucus, if you have mucus that only stretches a little bit, if you have mucus that's only present once or twice during the entire duration of the cycle, then there are things that we can do. There are supplements that we can give to help improve that mucus, to make it more stretchy, to make it more an increase in the volume. And just improving the mucus is sometimes enough to help a person conceive. There was a really awesome chart that when I was learning about NAPR technology that they used to teach, and it was a woman who had completely dry cycles all the way through. And then one day she was started on vitamin B6, which is fantastic. And, super simple to take, 500 milligrams once a day. And just with the use of vitamin B6, she was able to increase the amount of mucus, and she had some subpar mucus, but because she was aware of her cycle, she was able to identify the day of mucus, able to document that day of mucus. They were able to have intercourse and come together in the marital embrace on that one particular day. She conceived in that cycle, and they ended up having a beautiful child. So it is just such an amazing thing to be able to understand and to identify all of these things that God has given to us, and to be able to just identify the shifts in the cycle and identify when people can be active and intervene and be proactive in creating a new life with God. Then following the mucus, you look to, what are the cycle lengths? Do you have a really short cycle length? Do you have a very long cycle length? And those things also tip you off. If you're somebody who has very long cycle lengths over 30 days, I always consider, does this person have issues with thyroid? Does this person have issues with polycystic ovarian syndrome? Is there some sort of a prolactin issue there? For patients who have very short cycles, frequent cycles, I would straight away think of, do they have issues with low progesterone? You want to look at the post-peak phase, the time from your peak day, your last day of really stretchy mucus, to the first day of your period. And if those post-peak phases are very short, then it makes me wonder, do they have adequate amounts of progesterone to sustain that post-peak phase? And checking those levels is really important. So how do we check the levels? For people who are coming to me for fertility, I typically will have them do pre and post-peak labs. And it sounds ridiculous, but they actually do about 12 consecutive blood draws for me, starting at the time of rise in estrogen. So we do it, if somebody has 26, 28-day cycles, I would just say, okay, start on day 6 of your cycle and go every other day. And initially you just check estrogen levels, because there's no progesterone that's of consequence in the first half of the cycle. And then following ovulation, we would check estrogen and progesterone in the second half of the cycle. And we compare all those values to what is normal, so that by looking at that, we can tell, does this person have adequate amounts of estrogen to start off the cycle that can actually feed into the cycle and cause the LH surge, which then causes ovulation. And if there isn't enough estrogen in that pre-peak portion, then we know that we need to give this patient something to stimulate that ovulation, something to strengthen that ovulation. One of the things that we need to do just across the board is, I always ask people to use supplements that help to protect the eggs and the egg health. So coenzyme Q10, checking vitamin D levels and making sure your vitamin D level is adequate, and fish oil. So those 3 supplements kind of across the board for everybody, whether you're trying to conceive or whether you're just trying to avoid PMS and have regular cycles. That's kind of my across the board supplement regimen. Then for people who don't have, for people who do have issues with inadequate estrogen in that pre-peak portion of charting, I would suggest, considering the use of letrozole. Letrozole is way better than Clomid because Clomid actually reduces the amount of cervical mucus that you have. And when you reduce the cervical mucus, you're reducing that highway for the sperm and making it more difficult for yourself. Also, in the protocols that we use for Naper technology for letrozole, we use a slightly different dosage than we would typically, from what I read in the general literature, and it seems to work well. Then after you get through that initial part, you're looking in the post-peak phase. You're looking at after ovulation, what's happening with estrogen and progesterone. And there are several different, patterns that we see. Some people will ovulate, they'll have a healthy corpus luteum cyst, and initially it's gangbusters and you're getting adequate amounts of estrogen and progesterone, and then all of a sudden both levels plummet. Some people will have super high estrogen. They're estrogen overproducers. Either, maybe they're very overweight and their fat cells are producing tons of estrogen. Maybe they are consuming lots of xenoestrogens in their day-to-day, things that they're using, things that they're consuming. And so their estrogen receptors are constantly producing more and more estrogen. Maybe they just have intrinsic high levels of estrogen. But in those patients, you would see, because of this predominance of estrogen, you see this fall in the progesterone. And so you've got to figure out how to boost the progesterone, but also address the high levels of estrogen. And you can do that by giving certain supplements like DIM supplementation to try and change the way that estrogen is metabolized, but also having the person be aware of the importance of diet and exercise to reduce the amount of fat cells on their body, and to be alert about xenoestrogens and exactly what they're putting into their body so that they can eliminate those things from their diet, from their hair products, from their makeup, all of those things as well. Then what else? Let's see. Pre and post-peak labs, estrogen and progesterone, you really just try to supplement. There's different ways to supplement. You could use compounded progesterone, you could use generic progesterone from the regular pharmacy, you could use seeds that have progestational properties or estrogen type properties to them. And it's just also very interesting and exciting. But once you help somebody, I guess there's another thing. When you're doing all of this, so that's the charting portion and the lab portion of the investigation. We also do ultrasound. So you do a baseline ultrasound just to see, are there any fibroids? Are there any polyps? Because polyps would reduce the ability of somebody to have a pregnancy implant properly. It's kind of a 30% reduction, they've said. So you want to address all of those issues. If you have tail and brown bleeding at the end of your cycle, another thing that might be causing it, so say you take care of the progesterone issue, but it's still persistently there, it might be due to chronic endometritis. Chronic endometritis is just inflammation on the inner lining of the uterus that's been caused by some sort of infection. And you can test for that using an endometrial biopsy, or if you're doing a D&C for the patient and you're getting a sampling of the lining, you can test that lining for plasma cells and for infection, and then you can treat that accordingly. And oftentimes that will help a woman to be able to carry a pregnancy when otherwise she might not have been able to. So then you move on to the ultrasounds. Like I was saying, you get a baseline ultrasound, and then following that, at some point you could even consider doing a follicular ultrasound series to see if within that particular cycle, if the follicle is growing appropriately, and then if it ruptures appropriately, and if it completely resolves appropriately, making sure that you see an adequate thickening of the lining during that time, paying attention to the cervical mucus and the opening of the cervix during that ultrasound, making sure you're actually seeing, the fluid in the cul-de-sac after that cyst has ruptured, showing that it actually did rupture. So there's, it's very interesting being able to follow that to see if somebody has a complete ovulation. And when you do that, sometimes you will find something called a LUF, luteinized unruptured follicle. And then there are other protocols you can use at that time for those patients to help them rupture their follicles, to kind of soften the follicles before you stimulate them so that they have a better chance of fully rupturing their follicles and releasing the egg. Then you can still do, there are certain things that infertility doctors, reproductive endocrinologists do that as NAPR docs we also utilize. So the use of sonohistogram or HSG to evaluate the tube. Sonohistogram, typically it's when you put saline into the uterus and you're looking for polyps within that uterus, but you can also use it just to flush the tubes. I've had one patient that every time she does a sonohistogram, she manages to conceive immediately following, which makes me believe that there is something to be said about micro debris within the tubes. And when you flush out the tubes with the saline, that it makes it easier for the transport of that egg and for the embryo to move down that tube. You can, the hysterosalpingogram, you're inserting dye into the uterus and you're making sure that both of the tubes are flowing properly and there's no blockages in the tubes. Doing surgical intervention for a patient, laparoscopy to look for adhesions, to look for causes of pain, to look for endometriosis and to resolve that. D&C hysteroscopy to look inside of the uterus and make sure that there's no adhesions or blockages or polyps or abnormalities within the inside of the uterus. And then obviously we do semen analysis for the husband. Now, as far as the semen analysis is concerned, we do not ask that the husband masturbate because we believe that that's not good for them or anyone else. And we do not advocate the use of pornography in any way. So instead, we have the husband use a perforated condom and they collect the sample while they're making love. And then they can put that sample into a container and take it to a normal lab at their hospital to have it processed within half an hour. Or there's a group called ReproSource where they can pour it into that container that ReproSource provides. And then they mail it off and ReproSource will provide a lovely report with a lot of detail. And that's how we typically will do our semen analysis to understand if there's any issues with the man and his sperm, as far as, you know, what do the sperm look like, the morphology, are they able to swim well, the motility, is there adequate volume? And then there are supplements that we can give the husband to help him have better sperm and to help make them, give them a better shot at pregnancy. What else? Just trying to think down my list. So those are typically the main things that we would go through just as far as the evaluation. Once we get through all the initial evaluation, it's a matter of implementing the different treatments and then checking one monthly peak +7 level to check and see with the things that we're instituting, are the levels going to where we want them to go? Are they going to normal? Is the mucus adequate? Having a patient continue to chart and have focused fertility, focused intercourse with her spouse at the time that she has adequate mucus. We can also use a kind of a combination of the Marquette method using the Clear Blue digital ovulation predictor kit to help people to identify when that estradiol is rising so that they can make sure that they're using their mucus enhancers at the correct time so that they get the maximum bonus out of that. And those are kind of the main things. So if anybody has any questions, I know I just spewed a whole lot of information at all of you. I'm happy to answer any questions. I saw a couple of questions popping up while I was talking, but I didn't stop to answer because I lose my train of thought.
Thank you, Dr. Monique, so much. Thank you, thank you, thank you. Hold on, I'm trying to figure out how to show the video, and I think it's because I have so many things on my screen that it's like giving me loads of trouble. Thank you so much, Dr. Meek. Thank you, thank you, thank you. Yeah, like I think like that's so important for people to not only know the inside scoop of the IVF industry, but then to know how to actually help to make sure that they do have a little one, but to do it in a way that's ethical. So thank you, thank you, thank you, thank you. Okay, so yeah, feel free to answer any of the questions.
Let me see if I can find them in the chat. I saw.
So Cheney has one, or no, it's not don't think it's a question. It's more just a comment. But yeah, feel free to anything.
Let me see if I can find the chat. Okay, there's the chat. Let's see. What percentage of patients wanting to get pregnant whose health you assess have underlying health issues that interfere with getting pregnant? All of them. So every single person who's having difficulty conceiving has some sort of underlying issue that needs to be addressed. Otherwise, they wouldn't have any issues and they'd be able to conceive no problem. So that's the root of NAPR technology, trying to figure out what the underlying issue is, which is really, really fantastic. I think that was the only question.
Okay. Okay. So where now, like, I know the answer to this, but just so that everybody else on the call knows, and please share this information, anyone on the call, with anybody that you know that may be struggling with infertility, or may have lost little ones, to make sure that they have, that they know about natural fertility methods. Where would somebody find a NAPRO technology doctor, a natural infertility doctor? Because I know that there are lots. There's NAPRO and then other types.
Yeah, so I would suggest that if somebody is looking for a NAPRO technology doctor, that they actually Google NAPRO technology and their zip code and their town, and it will come up. Because if you go to the Pope Paul VI Institute and you look for NAPRO technology doctors, unfortunately not all of us are listed there, because after many of us got trained, they added kind of a secondary certification that lots of us haven't completed yet, that additional certification. There's like an additional test. And although we've seen tons of patients and we're constantly using NAPR technology, just the time to sit down and do yet another test, it's like, okay, haven't done it yet. So those of us who have not completed that extra bit are no longer listed on their actual website. So I always say, just Google NAPR technology physicians in your area, and you will find that somebody might pop up within, an hour or two of you. If not, if you can't find somebody, there are NAPR physicians like myself who do consultations for people in other states, but because I don't have a medical license in all of the states, what I do is I do coaching appointments for those patients. So I would listen to their history. I would advise them step by step on the things that they should ask their physician to write for them, as far as labs, as far as ultrasounds. And then they get those things done through their physician. And then they're welcome to coach with me again and share with me whatever information they have, and then I would update whatever recommendations I would have for them. I think one thing I forgot to mention, so after these people conceive, oftentimes their lack of progesterone is still there. So throughout the pregnancy, NAPR technology is a beautiful chart for pregnancy monitoring. So for all of my abortion pill reversal patients, for all my patients that have any history of low progesterone, I always offer to monitor their progesterone every 2 weeks throughout the pregnancy. And then we adjust the progesterone levels for them as needed. And unfortunately, it's not true in my experience that just because you hit 12 weeks, then you stop the progesterone, because many of the patients that I have, because we're monitoring the progesterone levels every 2 weeks during that pregnancy, we find that the progesterone levels are still inadequate. And sometimes we have to continue progesterone all the way to 37 weeks. And we're helping people who have a history of recurrent miscarriage due to lack of progesterone to maintain their pregnancies by monitoring this progesterone level. So that's really fantastic. I've had several patients with like 6 miscarriages, 8 miscarriages, and then they found NAPR technology and they found progesterone monitoring, and now they have 4 living children, which is just such a blessing for them. So maintaining that monitoring is really, really key in helping these women. And then even after they deliver, they still have an issue with low progesterone and they are at high risk for postpartum depression. And so giving them progesterone at that time is very helpful. And then after they're done with that, these women are at high risk for having severe PMS. And so helping them with ovulatory progesterone supplementation is really key to helping them maintain happy marriages and healthy lives in their families too. So, yeah. Sorry, long-winded answer for your very short question.
No, thank you so much. I so appreciate it. Thank you, thank you, thank you. Hold on, I am having so many technical issues. I'm trying to get my stream back on so that I can see all you guys. No, thank you so much. Thank you guys so much for your time and for your hearts for life. Thank you all so much for participating. Thank you, Dr. Caruso and Dr. Monique and Dr. Lyle, even though he's not on now, for sharing. Thank you guys all for your hearts and for your passion for life. And thank you guys, Dr. Caruso and Dr. Monique and Dr. Altman, even though I know that you're retired, but still, and Dr. Lyle, for your hearts to practice medicine in a way that truly shows the dignity and the value of every single life from the start of life at fertilization, no matter what. So thank you all so much. It's such a privilege.
So, Rachel, you are logged in as two people, Rachel Guy, the host, and Rachel Guy. And the Rachel Guy, the host that is recording, has no video.
I know. Okay, so this is the weird thing. Hold on. I can do video on my phone. Hold on.
There you go. Now you should have video.
Yeah, the weird thing is I don't know why, but my computer is not letting me like click on audio, and literally I don't even see you guys on my screen right now on my computer. I have no idea what happened. I can hear you on my computer, but I can't see you. So it's very weird. I have no idea. Technology is not my best friend at all. Maybe 22, but I can't figure it out to save my life. But okay, so I know we are almost out of time. Can I get everybody to unclick their screen, and then I can try to get like a big picture of everybody? Yeah, like show the video part. Oh, cool. Okay. Hold on. Oh, hello. Oh, wait, can you get Thea and Christy? Hi, Jonathan. Is Thea sleeping? Thea! Hello, little girl, I love you. Hi, cutie pants. Okay, hold on. I'm gonna have to take like a series of a few photos because of this, like my stupid phone. Okay, can I have everybody say cheese, and then I'll just kind of like click through my screen on my phone. Hold on. Okay, I have to make sure everybody, okay. Is everybody ready? Okay, 1, 2, 3.
Cheese.
Okay, cool. Thank you guys so much. This was so awesome. I will be sending, hold on. Wait 1 second. I will be sending you guys the recorded version of this. You can pass it along to anybody. And I'm taking screenshots also of the chat so that all the information that everybody shared on it can be passed along so that, yeah, we all know everything. And also, when I send out a blast email, I will copy